I'm Sean O'Driscoll from the Department of Orthopedic Surgery here at Mayo, and I appreciate the chance to share with you some thoughts about the research study that we'll be publishing in the July issue of the Mayo Clinic Proceedings, entitled Prospective Blinded Evaluation of Patient-Physician Agreement Using the Summary Outcome Determination. Now, this is a study that has a take-home message or a bottom line type of message, which is that the summary outcome determination is a bottom line way of looking at treatment outcomes in which patients and physicians agree very highly. There are three things that we learned. First, it's offering very high patient-physician agreement. Second, it's reliable. Third, it's simple and quick to use. The summary outcome determination has a categorical score and a numerical value for internal consistency testing, and so it can be used as a research tool. The patient is asked that compared to before surgery, do you feel that you are better, worse, or you're no different? And if improved, the patient is asked, do you consider that you have been improved, greatly improved, or almost normal, or normal? So 4 categories. And then a numerical score between 0 and 10, 10 being normal, 0 being no change from before surgery. So the findings were threefold. First, out of 100 patients tested prospectively, the agreement between the patient and either the surgeon or the physician assistant or the clinical fellow in training, or a combination, the agreement was very high, with 96% of the occurrences having agreement within the same category or within one category. Now, if we refine it further, 69% of the time, the patient and the doctor chose the same category of outcome, or if they differed by only one category and also by only one numerical point value on the numerical scale. So very high agreement. Second, it's reliable. It was distributed normally, and so we saw that the outcome parameters were stretched out on the normal distribution curve, separating out the groups into clearly distinct different groups. And it turned out to be independent of diagnosis or severity as well, meaning that it didn't seem to matter what the diagnosis or severity of the condition was. So there's good internal consistency when that was checked as well. And finally, it's simple and quick to administer. It took only about 1 minute to do so. Now, most scoring systems that have been tested have revealed poor agreement between physicians and patients. And this is probably due to the fact that we think differently about the same terminology being used. But now we find that we're on the same page. Patients and physicians understand each other using the summary outcome determination. And so we can speak in the same way regarding expectations preoperatively. We come out with the same bottom line type of evaluation from the outcome of the treatment. And we can use this as a research tool, talking with each other in research studies. Speaking of which, the next step would be to do some research on different specialties and subspecialties over a wider range of conditions being covered, and see if the same consistency and the same reliability and the same agreement between patient and doctor agrees as it did in this study. So the take-home message then is that the summary outcome determination score offers very high patient-physician agreement because the patient and physician are now talking the same language. It is simple, it's fast, it's reliable, and it can measure outcome in a way that matters to both the patient and the doctor. And therefore, as we move forward in this value-based era of medical care and do further research into determining best treatment strategies, we can improve what we can measure, as it has been said, and this is a way that we can accurately measure in a way that the patient and the medical care delivery team would agree on the outcome measurement, and thus we can probably make significant advances implementing this very simple method of evaluation of outcome. And in clinical practice, it's very useful as a simple, quick measure. When I walk into the room, I want to know, is the patient improved, not improved, or worse than they were before treatment, in this case, probably surgery? Would they consider they have been improved, greatly improved, or restored to almost normal or normal? And similarly, if my team member is telling me about the patient and I'm about to walk in and they say, patient is 3 months post-op, greatly improved, and 7 out of 10 on the SOD scale, I have a clear picture of how the patient is doing. If I'm about to walk in and the patient is -3 and worse on the scale, I similarly have disappointing but a clear picture of what's going on. So very useful in clinical practice. It will be useful in research so we can talk on the same page, and I think it will be very useful as we move forward evaluating the value of the care that we're delivering to patients. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.